is a respiratory physiologist, and she's a former clinical exercise respiratory physiology lab member. So she's a good friend of mine, and I'm very happy that she was willing to moderate the session today. So I'll hand it to her, and I'll invite our first presenter to prep a slide. I will upgrade that person as a panelist so they can present. So just give me a little second here. So yeah, Parsa, can you hear me? Should be on. Yeah, hello. So you can share your slides. Perfect. So yeah, Camilla, I'll let you introduce him.
I'll take over. Yeah, so like Felix said, my name is Dr. Camilla Illidi. I'm an exercise physiologist and sports scientist, and I specialize in respiratory exercise physiology and the mechanics of breathing. And I'll be moderating this session on the mechanisms of dyspnea, where we'll have 3 talks. Now we have had a cancellation, should have been 4, but we have 3. So each presenter will have a minute extra, so no need to rush. And I will send a message in the chat when you have 1 minute left, and then when you have reached the 6-minute limit. And then we'll also have a bit of extra time on questions and Q&A at the end, thanks to this cancellation. So I will let Parsa start the presentation when they're ready.
All right, thank you. Hello, everybody. So I'll just be presenting my project as of right now. So my project is the effect of familiarization on perceptual responses and exercise endurance time during constant work rate cardiopulmonary exercise testing. Now, to give a little bit of background information, the high intensity constant work rate cardiopulmonary exercise test, or also known as CPAT, is sensitive in detecting neurophysiological changes and or adaptations that are induced by various interventions such as exercise or pharmacological. And typically there's quite a bit of large variability in responses that are observed, and the reliability of the constant work rate CPAT is not well established in healthy and or diseased populations. Further, it's unclear if a learning effect is evident in the constant work rate CPAT. Now, the purpose of this study assessed the effect of familiarization and quantified biological variability during consecutive constant work rate CPATs. And further, the hypothesis was that an increase in exercise endurance time and reduced between test variability would be observed over repeated trials. The increase in exercise endurance time during constant work rate CPAT will occur despite no between test changes in key sensory variables such as perceived breathing or leg discomfort. So the method of the study was a randomized control study with 50 healthy participants that are sex matched. The study itself would be completed across 6 visits in a 3-week period. And for the first visit, we performed a medical screening and a familiarization incremental cycloergometry ergometry CPET, as seen on the image on the right-hand side. Visit 2, we randomize our participants into one of two conditions, a free breathe or chest wall restriction condition, which is a model for restrictive lung disease, followed by another incremental cycle CPET. And visit 3 to 6, we had participants complete a cycle ergometer constant work rate CPET in the randomized conditions determined on visit 2 at 80% of the peak work rate determined also on visit 2, and all these visits were separated between 24 to 48 hours from one another. Now, diving into some preliminary results, we can see that so far we have completed a total of 9 participants. And looking at the first graph, we see that exercise endurance time in minutes as a function of constant work rate visitations, we see that no main effect is actually present. And bringing your attention to the other graph, once looking at the coefficient of variation as a function of consecutive constant work rate visitations, we see that a main effect is present here. And looking at the multiple comparisons, we see that constant work rate visit 1 to 2 compared to 3 to 4 and 2 to 3 compared to 3 and 4 show no significance here. But as we collect more data, we hope to reveal more concrete patterns. Looking at some of the perceptual and physiological variables, so I can bring your attention to the top 2 graphs, we see that taking dyspnea intensity and unpleasantness as a function of time, we see that the data follows the trends pretty clearly between the 4 visits, and the significance of the conditions is also non-present, and neither is the interactions for both intensity and unpleasantness. Further, we see the same trends occurring for leg discomfort as well. And one of the physiological variables we wanted to show was heart rate, but just to note, we will be showing more physiological variables in the future as we collect more data. We see that the effect of test number here as well is non-significant, as well as interaction. So in conclusion, there was no main effect of test number on exercise endurance time. Between test variability decreased over repeated trials. No between test differences were observed for key sensory variables, and preliminary results suggest that a learning effect may be present for the constant work rate CPET itself. And for our future directions, we hope to increase our sample size to the targeted 50 people and partition our pooled data between our 2 conditions of free breathe and chest wall restriction. I would like to thank my colleagues, my supervisor, and NSERC for funding this project. I'm open to any questions and feedbacks. Thank you.
Thank you very much, Parsa. That was perfect, 5 minutes. Didn't have to send you a reminder. Does anyone in the audience have any questions? I trust Felix will unmute if anyone has any questions. I am happy to start. So for the clinicians in the audience, what would you say is the take-home message for the people that work with patients and dyspnea, and what can they learn from your study?
Yeah, so far with what we've seen and with some of our preliminary results is that using the constant work rate protocol, it suggests that we should be using 2 familiarization phases for this specific cycle ergometer protocol in order to negate any effects of falsely attributing a sort of improvement in exercise endurance time to an intervention, and just making sure that doesn't really happen. So that's kind of the key takeaway so far. But again, with more data coming in, this could change. So yeah, that's my answer for now.
Thank you. I think we had a question, a hand that was raised.
That was me, but Parsa just really answered my question. Was are they again? Is the perception changing, or is the use of the scale changing? Faisal Subhan published some work several years ago now, and showed that if you plotted shortness of breath measured on a visual analog scale against minute ventilation, the intercept, the level of ventilation that dyspnea arose actually got delayed with subsequent visits. And it was the first two that you saw that delay, that they got to higher levels of ventilation before declaring that they felt short of breath. The slope, the rise with further increases in ventilation didn't change, but it was that intercept that did. And it was associated with how many times have I used the scale, not how many times have I done the exercise test, but how many times have I used the scale. So I love the work. Thank you.
Thank you. That's really interesting. I'll definitely be looking into that.
And can you please remind us how far you are into the data collection now? Because you need 50 people, and what the sample size for the data you showed us now.
Yeah, so just the sample size I showed you was for 9 people, and so 9 people have fully went through the 6 visitation so far. But again, we're hoping to increase that even further.
And would you see, or do you expect, or have you considered the potential effect of fatigue as you test these people so intensely over quite a short period of time, or like you could say the normal period of time that we would typically test exercise tests during? Would you expect to see any fatigue between the tests that could influence your results?
So I assuming you're asking about like fatigue crossing over from previous visitations, is that? Yeah. So we try to separate the visitations at least by 24 to 48 hours to give the participants some time to recover physically. Although ultimately it's up to their decision to, whenever they can come in, we take it. And also we try to make sure that we kind of remind them to avoid doing any sorts of extraneous activities beforehand. So any weightlifting or heavy activities that could potentially affect their performance. So that's kind of how we try to control for that.
Okay.
Yeah.
Perfect. Thank you. I know Magnus has a question.
Hi, great. Thank you for a great talk. Interesting study. So can I ask, you said regarding the potential implications of these findings, that it could influence the comparison between groups in randomized trials. I wonder whether that would be the case, because you would have the randomization, right, and they would undergo the same procedures. But would the implication then rather be that you could decrease the variability in your data by doing serial tests potentially, but you won't get any bias?
So
because you will still have a comparison group that also would change with consecutive tests.
yeah, so sorry, can you just repeat the question again? I didn't quite.
Yeah, sorry. So it's as I understood it, I think you said that this could influence the findings in randomized trials, that you could attribute the change to the intervention.
Yes.
But I think, I mean, the control group would undergo the same sequence of tests, right?
Yeah.
So you would still have a change from the control.
So yeah. Yeah, I see what you're getting at. That's a great question. So comparing it to the controls, I would assume that, yeah, for sure.
Just something to think about regarding the implications. But I totally agree that if you do serial tests, you probably get a lower variability in your outcome data. And that means that you could lower the sample size. In the other end, you need to do more tests. So it's kind of a trade-off, might be. But it's, yeah, interesting.
Yeah, definitely. That's definitely something I gotta look into. It's a great point. Thank you.
Thanks.
Okay, so unless there are any more questions, we can move on to the next one. I'm just looking at, okay, we have.
Hi, Parsa. Can you hear me?
Yep.
Okay, great talk. Thanks a lot for that. One question, Parsa. You want to show learning effects over these repeated trials, and I think if you really want to show learning effects, you also should control for that there has not been any physiological improvement over the test sessions, like a training effect. How can
I believe that last part of the question got cut off, but I think I got the gist of it. It's seeing if we're controlling for like adaptations that occur through these trials. And one of the ways that we are looking at that is through heart rate changes throughout the 4 visitations. And so far, for our 9 participants, it's been pretty tight across the 4 constant work rate visitations. So that kind of indicates that there hasn't been a training effect present.
Could their exercise capacity improve or their muscle functioning improve already over 4 or 5 sessions? Could that be an option?
Yeah, that definitely could be something, but based off the literature and the stuff that I looked at, the 3-week period that we're trying to aim for, it's such a short amount of time that any meaningful changes based off adaptations in terms of muscle training and all that, it would not be that significant of an effect there.
Okay, cool work. Thank you.
Yeah, of course. Thank you.
Okay, I think we will move on to our next speaker. Thank you so much, Parsa. Our next speaker, I trust Felix will make the speaker ready. The next presentation is by Ian McConnell from University of Texas Southwestern Medical Center on the topic of exercise capacity and dyspnea on exertion in children 3 to 12 months post pulmonary embolism. So I will wait for Ian to be ready.
I'm trying to find him. So Ian, if you're here, can you manifest yourself, please? I can find you in the attendees.
I can't find it either.
Okay, so if he's not here, we'll move on to Alexandra Flannery, Dr. Alexandra Flannery. If you're here and ready, we'll move on to you. So,
yep.
So I'm promoting her to panelists. Yep, she's here. Great. Hello, thank you for being ready already.
Yeah, good morning. Can you see my screen properly?
Yep, perfect. I will start the timer when you are ready, Alexandra.
Delightful. Thank you so much. Good morning, y'all. I want to talk a little bit about neurophysiology and its role in dyspnea and COPD, which feels a little bit on topic today. As everybody's been talking about, predicting breathlessness is really difficult to do. We can talk about lots of different receptors, lots of different inputs that we can measure. And yet, on the other side of it is this experience of breathlessness that doesn't seem to be able to be predicted, right? It can correlate, but there's this kind of box in the middle. And I think we all know that the brain and neurophysiology is really that connection between what we know about the physiology of lungs and what connects us then to the human whole body experience of dyspnea. I come from pain research as well, and in the pain world, they have a similar trouble, difficulty that they've been working on as well, and they use a concept called central sensitization. Central sensitization bridges the gap between objective inputs and subjective experiences. You can think of central sensitization like the volume knob on an amplifier. So regardless of how hard you strum the strings on the guitar, based on what the volume knob is set at between low and high, you can change the volume or the experience of the symptom that you're feeling based on the volume knob alone, rather than necessarily what is how hard you're strumming the strings. This idea, which is prevalent in chronic pain, made me think pain is a sensory experience and dyspnea is a sensory experience. And can I use central sensitization to describe dyspnea as well? So my fellowship project was to do a prospective cross-sectional cohort analysis of patients in outpatient clinic who have COPD. We asked them a number of surveys about their shortness of breath. We assessed their central sensitization, and we did some chart review and tried to figure out what we could learn about central sensitization in COPD. It turns out that central sensitization shows up prominently in COPD. On the right in the light blue graph is the distribution of central sensitization scores across a number of people who are in an outpatient elective knee and hip arthritis replacement surgery. We don't have general population level data, but this is a generally healthy population, right? They're getting their surgeries. On the left is COPD, and you can see that the number of patients who are reporting elevated scores in the 9, 10, 11, 12 range is definitely higher than in the arthritis group. For reference, a pathologically high central sensitization score is 13. So you can even see that the number of people who have pathologically high central sensitization scores is higher than people who have a painful condition like knee and hip arthritis. I then tried to connect central sensitization to dyspnea. And central sensitization, it does affect dyspnea as well. I took two patients, one with low central sensitization scores and one with high central sensitization scores, and tried to use my model to predict what their dyspnea reports would be. For someone with low central sensitization, across the board, they reported across all different levels of the multi-dimensional dyspnea survey, low levels of dyspnea. For people with high central sensitization, they reported higher levels of dyspnea, particularly in that affective realm of things like anxiety, frustration, anger. The values themselves and the models were not whole values. I rounded to whole values to more accurately reflect what patients would respond on their 1 to 10 scales. What I want to do next with this concept is characterize out of proportion dyspnea. I'm so excited about the work that Dr. Ekstrom has done in trying to create a reference equation for dyspnea so that we have some sort of gold standard to compare to. I think if you take the number of people who have out of proportion dyspnea, you're going to find that they have high central sensitization scores, because for all of the guitar strumming strings that we're trying to hold constant in our CPETs, there's a volume knob that's been turned up that results in higher dyspnea that's out of proportion to what we're able to measure. And I think we can measure that using central sensitization. With that, I think we can phenotype dyspnea. I think we can phenotype dyspnea using central sensitization scores to say, is your dyspnea had a major component of centrally focused dyspnea that has high central sensitization, or potentially low central sensitization with dyspnea coming more from peripheral inputs? This would guide treatment by saying, well, if you have low central sensitization, then you may benefit from breathing techniques like managing auto-PEEP. But if you have high central sensitization, you might benefit from breathing techniques like managing your anxiety, right? There are also pharmacotherapies from the pain world in directly managing central sensitization that might help treat the dyspnea of these patients with elevated scores. Overall, here's what I want you to hear. Central sensitization is a concept that translates objective input into subjective experiences. Central sensitization correlates with worse dyspnea and COPD, and treating central sensitization might help treat dyspnea. My mentors are Dr. Daniel Quat at the University of Michigan, Dr. James Burke, and Dr. Philip Diaz here at OSU. This is my sweet mate in my office, Tucker, and I am here for whatever questions you guys have.
Thank you, Alexandra. Very good. Does anyone have any questions, either in the Q&A box or to ask over camera? Yes, we do have one. Well, we have two. So, okay, Felix will unmute.
Yeah, so it's Dr. Schweinstein that is becoming a panelist, I believe, to ask a question. So yeah, he should show up momentarily.
My question was whether somebody who has high central sensitization, if I'm using the term correctly, for pain, also has it for dyspnea. In other words, is this a trait, so to speak, of the individual that crosses different qualitative stimuli?
Sorry for the itchy dog in the background. Yes, what pain research finds about central sensitization is that all sensory stimuli are elevated with elevated central sensitization scores. These people also are sensitive to bright lights, bright sounds, odors. These are people who have multiple intolerances to medications. And they also have more orthostatic intolerance and autonomic dysfunction.
And I would, well, I think there are data, and certainly has been my experience in pulmonary rehab, that much of what we do with patients is desensitize them to the sensation. Would that be consistent with your work as well then?
I think there's probably a conflation of terms in what, like, generally, yes. I also think there's an imprecision in the terms of what central sensitization of the nervous system and the actually specific mechanisms of what's happening, and then what we are doing in pulmonary rehab. But I think you're right. We are acting on this concept, especially when we're getting outcomes like people feel better, even though none of their objective PFT data are changing.
So one last question, and I'm sorry for hogging the time here, but so are you saying this is a neurological change or an interaction of psychological and neurological inputs?
Yes, to all of it. The pain research has done fMRI studies showing how actual areas of the brain have increased signal in these areas, both on an affective realm of emotions and also the specific intensity of pain. So I think this is a unifying concept for these things that we're talking about how do we relate the affective anxiety to the disease severity. This is a concept that actually kind of pulls all of it together.
Thank you.
Okay, we have, I'm going to take one from the chat first, and I'll get to you, Rochelle. So we have questions coming in, actually. One from iPad 2021, asking, is the MDS actually the MDP?
Yes, I'm so sorry for the typo.
Okay, then that was clarified. And then we'll have Rochelle, Dr. Rochelle, go on first, and there are two questions in the chat that are pretty similar, so I'll merge them. Yeah, Rochelle.
Hello. Really nice presentation and very interesting. I'm just wondering if you can expand a little bit more on your thoughts about phenotyping, breathlessness, and central centralization into even like diagnosis process of COPD, considering like major or minor criteria, and then the treatment decisions. I'm just interested to hear your thoughts on how we can incorporate that.
Yeah, I think the COPD assessment test doesn't ask about most of the symptoms of central sensitization. So central sensitization in the pain world looks like, or actually just people with high central sensitization, that phenotypically looks like widespread pain with multiple sites of pain and concomitant mood, memory, and sleep dysfunction. So these people are irritable, they have trouble remembering things, or they have brain fog, and they have unrefreshing sleep. They can get to sleep, but they feel like they have unrefreshing sleep. These are symptoms that aren't asked about in the CAT, and part of me, like a big picture life goal, would be to redesign the CAT to take those symptoms into account, since central sensitization does seem to increase with it is increased in patients with COPD. I also want to look at this longitudinally to see how these things develop over time and the interplay of what happens, right, as you become deconditioned and as your disease process gets worse. Do these things actually end up feeding on each other to create worsening symptoms, worsening central sensitization, which then makes you more deconditioned? There is preliminary data in migraine, actually, that this is the case.
Thank
Did that
you.
answer your
That was
question?
great.
So I got a message here. So Nicole Dominic is next in the question line.
Thanks very much for that. I think a number of us are on a similar brainwave here, because as the questions were going through, I was like, oh, I was going to ask some flavor or variant of this as well, and actually with the chat too. I guess as someone who has not heard this concept framed in the way that you have before, and I'm quite intrigued by it. You briefly touched on in your example during your presentation about how you might look at one sort of treatment pathway as being managing sort of auto-PEEP, the other one maybe being managing anxiety. And so my first thought was, is this sort of do you see this as being a superimposition of sort of affective background state, or more things beyond that? You've touched on some of the factors that you think sort of are associated with people who might be more likely to have this kind of central sensitization as opposed to not. But where do you kind of see that relationship fitting in, I guess, is the first question. And then I think this might maybe sort of partly addresses one of the questions in the chat as well. As someone who's unfamiliar with the types of tools that are used to assess this, is that something that's probed in terms of like the origin story, or is it more just, is this a constellation of symptoms and manifestations that you have at this time, more independent of where it might have arisen from?
Yeah, thank you. You guys are asking like these amazing questions. I am a pulmonary fellow. I have not entered independent practice. I am hoping to get a career development award to like answer all of these questions. I can speak a little bit to what the pain world does. And the pain world, so I think here, so here's how you assess central sensitization. There's a number of ways to do it. There is no exact gold standard, but this is one of the most common ways. You assess widespread pain by asking about the number of areas of pain. And you just put a map down, like mark with the number of X, the number of places that you've had pain in the past week. And then people just like all of a sudden come out of nowhere. And then you ask about their non-pain symptoms, which are fatigue, waking up unrefreshed, cognitive symptoms, and then a little bit of, over a longer period of time, headache, abdominal pain, and depression. So that's how we assess for it. And I'm so sorry, like, give me one word to remind me of the first part of your question.
Yeah, just I think because you kind of scratched an itch in my brain when you said sort of treating the anxiety component rather than treating like the physical manifestations. And so I think sometimes people are prone to, and I will lump myself to this category, there's a sort of a default to want to say like, oh, is this maybe just that someone has, for example, underlying anxiety or some sort of change in affect that leads to a perception of higher sensitization. But am I being reductionist and sort of going there that quickly, or how do you see that kind of fitting into the constellation of factors contributing to this?
Yeah, so let me speak to what pain does, but I think there's really close parallels here. Pain has done a decent job in connecting one to, right, to saying like central sensitization causes is this driving factor, and then you're looking at these components of it, right? What they also know is that these are a cyclical thing. So for some people, their anxiety and depression feeds their pain. For some of them, their pain feeds their depression. And so there is actually no causal loop, right? Because for some it goes this way, and for some it goes the other way. And so I don't know that we can necessarily say, right, like just your anxiety will get to manage your symptoms. But we do know that uncontrolled central sensitization, uncontrolled pain leads to worsening mood symptoms. And so I think I was really interested in what somebody said earlier about when they were in the hospital and their anxiety worsened their asthma symptoms, right? I think that's one example of this going kind of in this direction, from the symptom back to the central sensitization, where the volume knob is getting turned up. And it's how do we turn that volume knob down? And I think baseline, maybe people with chronic disease probably have stickier volume knobs that get stuck up higher, and we have a harder time getting them to turn down. As opposed to people whose volume knobs are still relatively mobile and they don't have really like stuck catastrophization. This is never going to work. I'm never going to be able to do this types of anxiety. I don't know if that answered any of your question.
That did. Awesome. Thanks very much. And I like the knob analogy.
I think we have time for one more question, if we can just keep it within 2 minutes, and then Ian is going to be ready for his presentation afterwards. So last question from Valentina in the chat here. Do you think the age or comorbidities of the typical COPD patient may cause them to develop central, well, I'll just abbreviate it, CS, as opposed to CS being the mechanism behind their dyspnea perception per se?
A totally separate part of my research agenda is to look into the ways that increasing numbers of comorbidities contribute to central sensitization over time. In my models, I did not see a correlation between central sensitization and the Charlson Comorbidity Index. That was a pretty flat line. Those are also it was also kind of pretty blunt, and I wasn't able to get much nuance into there. There is association with age and pain necessarily, but I haven't really been able to tease out the central sensitization part of it. I do think because of, those of us who are clinicians who have seen patients who are super, super sick and they feel terrible, and you're like, oh, well, I can't point to any one thing, but I totally understand why you feel awful. I think central sensitization building over time as this kind of like feedback loop mechanism over time can worsen those things as people get older. Yeah.
Okay, thank you. I hope that answered Valentina's question. I don't think we have time for more questions, but thank you very much, Alexandra. That was good, and good questions we got there too. We will
Thank you so
move
much.
on to Ian, who is now ready to present. We had to swap the order a bit, but Ian is presenting from the University of Texas Southwestern Medical Center, and I trust Felix will prepare Ian.
Great. Hi, y'all. Thanks so much for being with me today. Let me just start sharing my screens here. Okay. Just confirming here. Is everybody able to see my screen okay?
Yeah.
Okay. Well, first of all, thanks everyone. Thanks for being here. Thanks for listening to me, and thanks for accommodating my tardiness this morning. I greatly apologize. And I'm a medical student over at University of Texas Southwestern. I'd like to talk to you all about a project I did in Dr. Babb's lab earlier this summer. So to start things off, the incidence of pulmonary embolism is increasing in children, and the mortality is decreasing. You can see this on the graph over here at the left, which makes it increasingly important to address the complications post-PE. One of these complications is persistent dyspnea, which is linked to worse quality of life scores in children and worse functional outcomes in adults. However, the mechanism of this dyspnea is still unknown, and as is the evolution of dyspnea during following PE, particularly within the first year following pulmonary embolism. So our lab wanted to address these knowledge gaps and evaluate the change in dyspnea and change in exercise capacity in post-pulmonary embolism survivors from 3 months after pulmonary embolism to 12 months after pulmonary embolism in pediatric patients aged 13 to 21. And we can take a look at the graph on the left here, and this is all participants at 3 months. Post-PE children are in blue, and then controls are in orange. And on the x-axis, you can see we have peak VO2 as a percent predicted. This was calculated using cardiopulmonary exercise testing to exhaustion on a stationary bike, and percent predicted was calculated using the Cooper equation. On the y-axis, you can see RPB, or subjective breathlessness, ratings of perceived breathlessness using the Borg scale, 0 to 10. And this was not calculated at maximum testing. Rather, this was calculated at 40% predicted peak wattage or steady state submaximal testing. And the graph here is giving us a distribution at 3 months. And we were interested in dividing these participants into groups, then looking at how these variables, how peak VO2 as a percent predicted and RPB at a steady state changes between these groups over time. And so we conducted two analyses for this. The first one, if you look at the vertical red line, divides folks by peak VO2, above or below 80%. Above 80% is normal capacity, below 80% would be low capacity. In a parallel analysis, we looked at RPB. This is the horizontal red line. 3 or above would be categorized as patients with dyspnea, participants with dyspnea, and below 3 would be without dyspnea. And we wanted to see how variables like peak VO2 and RPB would change among groups over time. Similarly, we also conducted or looked at other CPET parameters like VE, VCO2, cardiac output slope, respiratory exchange ratio, stroke volume, and also conducted PFT testing in parallel at 3 and 12 months. So here's some of what we found. On the left here, there's an analysis where the groups were divided by exercise capacity. So this is the analysis when we divided them by exercise capacity. And you see RPBs on the y-axis here. You can see that in the low exercise capacity groups, folks initially demonstrated a higher RPB at submaximum state. However, you see by 12 months, there's a fairly substantial decrease in RPB. And then the folks with normal exercise capacity started low and then finished low as well. On the right here, you see the same graph with the other analysis, with the dyspnea analysis. Folks starting with a high RPB were quantified as the with dyspnea group. So this is how the groups were categorized. So of course, the with dyspnea started with a higher RPB. But you can see at 12 months, there's a pretty profound decrease in the with dyspnea group, whereas the without dyspnea control started low and finished low at 12 months. These are looking at the same two analyses when folks were divided by exercise capacity and folks were divided by dyspnea on the left and right respectively. However, in this instance, peak VO2 is on the y-axis. So looking over at the left, we see the peak VO2 as a percent predicted was initially obviously lower in the low capacity group, but it didn't change very much from 3 to 12 months, unlike RPB, which we saw a decrease in. And then normal capacity obviously started higher and also finished at a similar peak VO2. There wasn't a significant change. We can see, despite changing the analysis and looking at folks with a high and low RPB on the right, there was similarly not a substantial change in exercise capacity in either group. Importantly as well, there were no differences in QC slope, VE, RER, or end-tidal CO2 at maximum testing between groups or over time in either analysis. In addition, there was no change in VE, VCO2, or DLCO between groups or over time in either analysis as well. So where does this lead us? Well, in terms of exercise capacity, no matter if groups were divided by RPB or if groups were divided by peak VO2, the exercise capacity remained unchanged over time in all groups. And this is in the context of stable cardiorespiratory parameters. So in other words, when looking at the low capacity group at 3 months to 12 months, not a lot changed. And when looking at the low RPB group, or excuse me, the group with dyspnea, they had a low exercise capacity at 3 months and 12 months in the context of unchanged other CPET parameters. So this indicates that deconditioning may play a key role as a potential mechanism of exercise limitation in post-PE patients. In addition, another conclusion we can draw is we see a pretty profound decrease in dyspnea on exertion in the group with dyspnea in the dyspnea analysis and the low exercise capacity group in the exercise-based analysis. However, other cardiopulmonary respiratory variables that we recorded were pretty stable. This supports that there could be a psychophysiologic contribution to a genuine symptom burden, a genuine dyspnea on exertion in post-PE patients. These are some of the findings that we've had so far. We look forward to investigating this more, and this is briefly what we found so far for the project. Thank you all sincerely for your time. I'm very grateful to be here and very happy to answer any questions that y'all might have.
Thank you, Ian. I already see that we have a question from Devin Phillips. So you can.
Yeah, please.
Hi, Ian. Thanks for your talk. Very interesting. Looking at post-pulmonary embolism dyspnea, something that I have some interest in as well. I'm just thinking in the one group that had the high Borg score at 3 months compared to 12 months. And obviously their dyspnea went down substantially with no change in VO2 peak predicted at least. I'm just wondering, was there a subset of individuals that remained dyspneic after, like maybe even a small sample, like 10 or 15% of them? Did they remain at a high Borg value over time? And further to that, if there was a group like that, did any of the resting physiological parameters predict that, such as like DLCO or static lung volumes or something like that?
Yeah, that's a really great question, something we wanted to look at as well. There was a subgroup that did maintain the same level of dyspnea, that their RPB didn't change significantly over time. It started high and it did stay high. However, this was not correlated with an increased DLCO or an increased VE/VCO2 ratio at submaximum or threshold. So that was a great question when we wanted to look at that, but we couldn't correlate it to any other parameter.
Does that answer your question, Devin? I trust it does. We have a next question from Richard Schwartzstein.
Good, thank you for the presentation, very nice. Were you looking at either with echoes, if not right heart cath, pulmonary hypertension in these kids, and whether that was a variable that could also have been explaining some of what you found?
Yeah, that's a really good thought, and I should have included that, these are very preliminary, and further imaging and studies are certainly necessary to rule out more occult cardiopulmonary pathology post-PE, like subclinical retained thrombi, something like that, or right heart strain. So we were not able to look at that. The initial intention of this project, this was an aspect of a much larger cohort, a much larger project that was attempted. Is kind of undergoing right now, but we didn't look at right heart cath or any echoes during this, but it's definitely something we would like to look into.
And one other related question, I don't think of pulmonary embolism as just occurring spontaneously for the most part in children. Do they have underlying illnesses that predispose them to that and then might have contributed as well?
Yeah, that's a good question. So we filtered the participants to not have certain, like none had malignancies, none had comorbidities that we thought would independently limit exercise capacity. A large proportion of these were idiopathic or secondary to oral contraceptives in many cases, but not something like disseminated malignancy or anything like that we thought would limit exercise capacity independently.
Great, thank you very much.
Then we have a question from Magnus Ekström.
Hi, great, interesting stuff. So we have a paper just accepted that have looked throughout the CPET. This is in grown-ups. Which is the best point during test to actually grade the severity or the abnormality of exertional breathlessness? And it turns out that the higher the physiological stress or the exercise level, the better. So this is using the reference equations. So it turns out that using the peak values are best. So I'm just thinking, I think it would be interesting to look in other populations and in children and other different age groups, and also so that's a suggested paper that you could look into that. But it might be that you misclassify some people. And I think it's also might be according to the underlying principle of incremental tests that abnormalities, they show more at higher stress levels than at lower, because you categorized it at 40% of the predicted, was it?
Yes, 40% predicted peak wattage, and that's really good insight, and I appreciate that. I would love to look at that paper because with just preliminarily looking at our participants, it looked like the dyspnea very much equalized at maximum testing. It seemed like everyone had a very high RPB at maximum testing, and we presume this was because everyone was giving similar effort to exhaustion, and so that everyone would be relatively dyspneic at a high exertion near maximum testing. But that's very good insight. I appreciate that.
So that's absolutely true. So the thing here is that, but then if you standardized it to the underlying variable, or you standardize it to normal references, then it's most informative at peak, because
Okay.
that's where you have the highest physiological stress, and that's where you're most likely to show abnormality. So yeah, so that might be something to look into.
Yeah, thank you so much. I'm excited to look into that. I'm excited to read the paper. So thank you so much for sharing that.
And I don't think we have any more questions. Felix, you can correct me. I sometimes don't see the questions come in, but while we wait, how did you monitor your participants between 3 and 12 months? Did you have them register their physical activity? How did you monitor this?
Yeah, and right now when we're writing this up, we're trying to incorporate, subjective reported activity levels between 3 and 12 months because we did survey them on if their activity changed or if their subjective reports of dyspnea on activities of daily living changed. However, we're seeing pretty inconsistent results, and it's a little bit more difficult to interpret the subjective reports from these children. It seems that there's a little bit less validity in some of their reports, and there's more inconsistencies that make it difficult to interpret. But ideally, what we wanted to see was, could we correlate this subjective RPB at submaximum testing with subjective rates of dyspnea during their activities of daily living, during going to school, during getting lunch in the kitchen, other ADLs. But so far, we haven't been able to see that.
Okay, thank you. And since there's no other questions right now, I'll ask the last question, which I usually work with adults, and I know most of the members that I know in this attendance also work with adults. Some work with older adults, especially. You're one of the few people here that actually work with children or teenagers. Can you tell us a bit about what that's like? What it's like to test them, what it's like to work with them. You talked about, school lunches, and you have to schedule presumably with parents as well. What is it like doing this?
And honestly, most of the team that I worked with conducted most of the analysis firsthand, so they probably could speak better on that than I could. They've had much more experience and are much better at that. But they've told me, and the children that I have worked with, it is interesting. It seems like many of them are able to reach a level of exhaustion to a larger extent than some adult populations. They've been through a lot having the pulmonary embolism. Many have almost died secondary to the pulmonary embolism, and they're very driven and they're very determined. And it's very motivating and inspiring to work with them. In terms of the logistics, it is difficult to find participants because they themselves are not, independently coming to us. There's a lot of other logistics they have to navigate, including, like you mentioned, school and, parental obligations on top of that. So from that end, it is logistically difficult, but it is certainly a pleasure to work with them and very inspiring.
Cool. Thank you.